bright and talented researchers here who are going to help you to look at your projects a little bit more closely in terms of decisions around study design. So I will let you.
My name's Lane Humphrey. I'm with the University of Delaware, and our project is Tastimals, and we're working with the brain students too. It's a project around.
Look at these guys.
Sure. I wonder we could write.
Yeah. And I'm Heather Bittner-Fagan, and everybody here really probably does know me by now. So.
I am Dina Chisholm. I am with Christiana Care. I'm a community educator for Swank Memory Care Center, and I also support Dr. Bateman.
My name is Terry Hancherik, and I'm with EPIC, a nonprofit that supports people in the community with disabilities and doing things of their choice. And I'm working with Eva.
Obersikova from the University of Delaware, and our project is around inclusive fitness for individuals with intellectual disabilities.
Good morning. I'm Jane Bowen. I'm the program manager for ARC, Adolescent Resource Center with Children and Families First. And I'm working with Dr. Krishna White on assessing parents' attitudes, knowledge, and preferences for LARC methods for their adolescents. Long-acting reversible contraceptives.
We all know that now.
Implants and IUDs.
Yeah.
And I'm Krishna White. I work with Jane on the same project.
And I'm Andrea Huertas. I'm the community representative. I work with Lindsay O'Donnell, and we're doing knowledge and interest in palliative care.
So I'm Mia Pappas. I'm an assistant at the University of Delaware.
I'm Claudine Jurkovitz. I met most of you last time, and I'm a nephrologist epidemiologist here in the Valley Institute.
I'm Marcy Dream, an infectious disease doctor, and I work as a hospital epidemiologist.
Lee McCormick, admin and research assistant, and I think everybody here knows.
We're in person.
Okay.
Who's on the phone? Who's on the phone?
Oh, and you guys on the phone, can you introduce yourselves?
Yes, I'm Omar Muhammad. I'm here in Charleston, South Carolina, and I'm a community representative for the Charleston Community Research to Action Board, and I'm working with Dr. Nichols.
Hi, and I'm Michelle Nichols. I'm an assistant professor here at the Medical University of South Carolina in Charleston. And as Omar said, we'll be working together, and I am new to the program here. I will be transitioning, taking over for Jamel.
Jen is hiding.
Jen is hiding. Hi, Jen.
Oh, and then you know me, Jen Passarella, Program Coordinator for the Community Engagement and Outreach component.
Great. So we're going to talk a little bit about study design, and then hopefully sort of springboard into a discussion on each of your sort of projects, and keep the majority of the time for some lively kind of in-depth discussion on your projects and where you are, and what your design is, your study population, maybe talk about sample size considerations, and while you have Claudine, Muncie, and myself here to really go into depth. So first I'm just going to kind of talk about what the role of an epidemiologist is, and if you are thinking as your project goes on as to whether or not you need or want sort of consultation from an epidemiologist. Classic kind of epidemiology research study designs, what they are, and I know we've sort of read a little bit about your projects, and some of them fit sort of what a classic study design would be, and some of them don't, and that's okay. And then sort of we're going to go through here the 4 things that you can sort of start thinking about for each of your projects, and really kind of flesh out your study population, who that is, how you're going to be sampling, your sample size and sampling plan, what that really looks like, and then talk really about your study implementation and how to make sure that you have quality control within that study implementation, and then a little bit about questionnaires, interviews, and surveys. And a lot of you, I think, are using some kind of survey or surveying individuals, and where you are and have you thought about the questions you're going to be asking and what that's going to look like. And stop me anytime if you have questions or you guys want to chime in.
Leave that up for one more second.
Leave it up for one more second. And I think that are these. I think you'll get copies of these eventually.
We will make them available on the website.
Yep.
I just want to make sure I'm thinking about the right stuff
Oh
as
yeah.
we roll.
So think
forward.
about study design, study population, your sample size, and sampling plan. How you're going to implement your study, what measures of quality control, and then designing your questionnaires, your interviews, your surveys, or however you're going to collect information.
Thanks.
Okay, so hopefully you guys are not here, that you've moved sort of through this idea of what my research question is to, and a lot of your plans were really excellent, I think, this year. The studies that you guys have all proposed have been really great, and you've thought through a lot of these particular issues. So this is just a general, like, why do we do research? So I'll ask you guys first. Very nice, sort of an easy question. Why did you want to do research, or for the community partners in the room, or what interested you in doing research around your topic?
I'll start.
Okay.
There's a really strong statewide effort to emphasize LARCs for birth control, particularly for adolescents. And Krishna and I thought that, we really, in order for it to be successful, there has to be parent and community
Buy-in.
Buy-in,
Yeah.
for this, or otherwise it's not going to work. And even though adolescents can access birth control confidentially on their own, we still need there to be a large sort of consensus about the efficacy and the people supporting it. So we just thought that we needed to do some research so that we could educate parents and also assess their knowledge, so that in the education of parents in the community, we knew sort of where they were coming from and what the best approach would be.
Perfect. So you're getting sort of a baseline too, sort of, because you're starting. Like
Right.
LARC is relatively new, right?
Well, LARCs have been around for a long time, a really long time.
It's like something coming back in fashion, like bell bottoms, or they're new now, but
Right,
they're
right.
30 years old.
I mean, all the way back to the Dalcon Shield,
Yeah.
But so they've been around for a long time, but there's a new incarnation of a new emphasis.
Great.
For me, I mean, my interest, I've always been intrigued by end of life. And so the opportunity to kind of get a sense in regards to, in Delaware, end of life seems to be a little bit unique from the perspective of I don't think there's a good understanding about what's available for palliative care and hospice care. And today there are no outpatient or community-based palliative care programs. So is there an opportunity for us to meet a need in the community that they don't realize exists? And I think the other thing that's pretty interesting is, the person's perspective of their sense of well-being related to the level of care that they're receiving. So if I have stage 4 cancer, but I think I'm doing great, am I at the right level of care when it comes to home care? Yeah.
Oh, sorry.
No.
Great. And so either one of you, have you done research before in these areas, or are you new to kind of asking a question in a systematic way and really going about getting?
The only thing that I have done, I was involved with Dartmouth with an Atlas project. It was reclaiming end of life with Ira Byock, and we did focus groups.
Okay.
And actually people had keypads to answer questions, but that's about what I've done.
Okay, that's great. How about you?
I think we're new to this like funded research. We've done like little things for your program. You've done research. I've done little things, but nothing to this rigor, I would say.
Awesome. That's great.
And for us, there isn't a lot of
There's not a lot of
evidence-based on evidence-based strategies for people with intellectual disabilities on exercise and fitness, and the reasons why they don't go to the gym, and how do they learn their fitness routines, and what's the best way for them to learn and to teach them and to become independent after learning the different options for them.
And so your goal in this is really to
test the effectiveness of these strategies that we came up. There's actually a much larger model behind it, but we're only taking a component of that model, and we're going to apply for NIH over the summer to fund the different stages of the model, and this is the second stage. Actually, the first stage is taken care of, that's the second, and then it's the third. So the second and third will be applied for. We'll apply for it in the summer. This is just the instructional strategies to get them into the fitness center and work effectively, and allow them to learn while they are exercising.
So, in general, our goal is to, and part of the mission of our center is to get more healthy foods on the plates of people who don't normally get them, or don't get enough. And so we're working at the zoo, and the answer to the question is why are we doing this specific research?
Yes.
So we have this exciting opportunity to work with the zoo, and concessions are a place. There's a great crossover between the efforts of the Brandywine Zoo to promote health in general and environmental health, and the opportunity to changes in the concessions and see how folks receive that and embrace it.
And you've done research before, or at least the center has.
Yes, a lot of food research and a lot of concession stand research and a lot of corner store research, so that kind of, front line, what are people eating and how do we get more healthy options.
And how about the zoo as your partner? They're interested in kind of doing research and the sort of outcome?
Yeah, they're amazing. They're amazing. Mike Allen has been here almost every single time. Is actually really interested in this, so he's very motivated.
He has some research background.
Yeah, he does. He was asking really great questions, wasn't he?
He's a community investigator, and when we were doing the quantitative stuff, some of the questions he was asking made me talk to him afterwards. He's done statistics and data analysis, and very cool. So.
Okay, who's it? Omar? Are you on the phone?
Michelle.
And Michelle?
Yes, I am. Sorry, I was on mute.
No, that's okay. So can you just give us a little, what kind of motivated you to ask this research question, why you're interested in research, kind of thing?
Sure. This happened back a long time ago. Maybe in 2005, 2007, we were awarded a NIH grant where we wanted to establish a baseline of contaminants in our community. Our community hosts numerous TRI sites, Superfund sites, brownfields, that the community felt were negatively impacting their health. So we wanted to establish a baseline of these contaminants in these pollution sources. So we were successful in doing that. Now our second round of questions that are coming out of that specific research is what impact health-wise is this having on the community? So now with this grant, we have the opportunity to establish a baseline specific to health. So what we plan to do is survey the community's health and be able to establish a health impact assessment. And we're going to be using this specific data in comments to a environmental impact statement that is coming here soon with the intermodal facility that they're building next to one of our communities. So it's going to be very helpful when that event happens, that we'll have some real data to be able to back up our claim.
What kind of facility are they building?
They're building an intermodal facility. It's going to support the port expansion on the old Navy base, which is right next to two of our communities. Both of these are going to be right next to it. So we're talking about increases in truck traffic, train traffic, ship traffic. So diesel exposure is really our main concern, is the impact to people's health from the diesel emissions, all the air quality that we think is going to be impacted from the activities from the port.
Do you have so you did the environmental monitoring? Do you have air pollution monitors?
That is correct. We have some. The community have 3 air monitors themselves. We have one. We have one up now. We are working with DHEC, which is the local health agency, with analysis of that data, as well as the mitigation that we succeeded with was successful with the State Ports Authority. We have a monitoring plan with them. So post-construction, they are going to put up an air monitor near their facility, as well as some of our comments for the intermodal facility. We want a monitor there as well for their facility as well.
Great. Awesome. So I think that one thing that always sort of intrigues me is sort of the motivation for why you ask sort of the research question, and then bringing that, like, why, that kind of anecdotal, that I had this experience, or, you know, from my clinical practice I think this, to then bringing that through to asking a systematic question, doing a systematic study in a way of really understanding them, and then being able to take those results and implement a program or sort of make change. And so it's interesting to kind of see that motivation and now bring it to an actual systematic research process. So what is research? I think everybody kind of knows what it is. So you're all sort of inquiring into sort of a question, and the thing to really keep in mind is that, you know, this is a systematic investigation that is purposeful, and I think you're all sort of there in thinking through, you know, and we're here to kind of help today to think through the system that you have in place to conduct your research, starting with a sort of study design, or the most appropriate study design for your research question. And these are kind of the general steps to any health research project, so you can see sort of how far you are along this continuum is sort of identifying the study question, which you all have done, and then selecting the study approach, which is what we're going to talk about today, and what you think your study approach is, or how you've selected that study approach, whether it's focus groups or whether it's a survey or whatever kind of study approach you have decided upon. And then are there ways that you can design your study that might help improve the quality of that study approach or the quality of the data that you get? And then I think Claudine talked a little bit about data analysis last time, and how you sort of analyze your data once you sort of and that's something to keep in mind while you're collecting data, is how you're going to analyze those data and then report your findings. And so what is epidemiology? So we're all sort of epidemiologists here. And so what we do is study the distribution and determinants of health and disease in human populations, right? So you think about how disease is distributed in populations, whether the determinants of that distribution, for the goal of prevention and control of health problems. Right? So it's kind of like what an epidemiologist studies, and what we all sort of have expertise in doing. And if you think about the steps of the sort of research process, an epidemiologist really can help along the entire continuum in understanding methods that are used to appropriately identify a study question, select a study design that would be the most appropriate given your study question, go about collecting data so that you've minimized things called bias. Has everyone here heard of bias? You don't want biased study results, and so how do you minimize bias in the design and implementation of your study? And then analyzing those data, how do you best analyze those data? So an epidemiologist and also a biostatistician would help do that. And then a way of how do you interpret those findings and think about associations and causation. So sort of an epidemiologist runs the gamut of the research process and help along the way. So this is my, research is like the house, and epidemiology really provides the foundation. And this is my epidemiology-centric view of the world. I am an epidemiologist, I will proudly say. So, okay.
That's pretty cute.
That's just me, so you know where I'm coming from. And this is the view, I think, of epidemiology in the rest of the world, is this random medical news. So what is it today? Today it is coffee causes depression in twins, and then that's the latest. And so a lot of epidemiologic research gets reported in the news. We hear about it all the time, like what's the latest healthy thing we can eat or not? What's the latest effective contraception or not? And so there's also a lot of misinformation. So I think we're also here, and this whole process is set up to help avoid the random, this exposure causes this outcome, and it's just association and not causation, and how we can better design studies and better report our findings so that this isn't eventually. Yeah.
I just want to tell a little tiny story.
Yeah.
Really quickly, I went to see my grandmother about 6 months before she died, and she asked me, "What do you do?" And I answered her like 4 times, and she kept saying, "But what do you do?" And finally I said, "Okay, well, we're working on a study where we are looking at, do people who get really upset and stay upset have better or worse health outcomes than people who get really upset and resolve what they're upset about?" And she looked at me for a moment, and she put her hand on my knee, and she said, "Everybody knows that, dear." So, but it was this really
That's the
important
grandmother test of your research question.
Right. But what was really important about it was that I realized that part of the answer to that question is we're adding to the body of knowledge that allows people to create policies that might impact those situations, and to create interventions that might help impact those.
Right, because if everybody does know it, then what do you do about it?
Exactly.
Right. That's great. Good. Okay, and then this is just kind of from the Surgeon General. So, epidemiology and I think science in general, we've sort of thought about this for a long time, that statistical methods don't really establish cause. But cause is kind of what we're aiming for, right? We want to find those exposures that are causally associated with our outcomes so we can intervene and it will have an effect. Statistics can't help us do that, but epidemiologists can kind of think about how we can design studies to reach more of a causal association, right? And so, but it's really a matter of judgment, not necessarily statistical probability. So there's this balance between designing a study and then doing your statistics. And statistics are great and they help us find the numeric associations, but then how do we actually interpret those associations when we get them? A little bit about what here is the epicentric lens. I like this slide, kind of thinking about once you've collected the data and you've found kind of an association, how do you think, or how are you going to interpret what that association is? And you have this observed effect, and then you have to think about, did I appropriately or adequately deal with information bias, which is, did I, in a unbiased way, collect information from people, right? Did I have a good validated survey? Did I have good quality control measures? And how I collected that information, right? Or was there some kind of bias involved? And did I select the right sample, right? Did the people who I selected to be in my study, were they a simple random sample of some general population? did I have loss to follow-up? Did I have losses in my study sample over time that maybe leads me with a biased sample? And did I think about confounders or confounding? And so that's something we think about in the statistical sense. Did you talk about confounding? That, once I look for an association between an exposure and an outcome, and I find that association, are there other factors, right, that might be involved in influencing that association? Have I really controlled for all of these other factors? And if I can say, yes, 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 I've designed my study, I've done my analysis, I've controlled for all those factors, then I get my observed effect closer to my causal effect, which is what we're all sort of shooting for. And then there's different types of study designs that go along with where you might be in the sort of bigger research picture, right? And so you might be here in the, I'm just collecting some descriptive data, like nothing is known on this subject, and I need to just collect some information so I can describe what's happening in my study, in my population. Right? Or you move from then, once you describe what's happening, to then asking a question and coming up with some hypotheses based on what you see, right, in your data. And then once you've developed that hypothesis, you're going to then test a hypothesis. And so these are kind of descriptive studies, and we move from just general descriptive studies to really testing a particular hypothesis, which is called an analytic study. Right? So do I just want to describe and get a baseline sense of what's going on, and then use that baseline sense to develop my hypothesis, and then use that to then test my hypothesis in a more rigorous way, eventually developing intervention? Or maybe this has already been done and you're at the point now where you're developing an intervention, and then you want to test that intervention. Right, so to think about kind of, and we'll talk about where you think you are as far as this continuum. Are you in the describing what's going on in a population in order to generate a hypothesis? Do you feel like there's enough that you know about your population to really now be testing a hypothesis? Or are you really at the point where you have an intervention that you're actually testing? Oh, here we are. Sort of within that method. And then depending on where you are, sort of leads to then what kind of study design you might choose. And these are common study designs. Some of the most common study designs that are used in epidemiologic research. So there's the editorial and expert opinion. That's the one person, the anecdote, kind of, or actually this is the I think, because I'm an expert in this subject. Right, that's that. Then there's the I saw this one person and that kind of led me to believe something, and it was strange or unusual, and I'm going to report that. To the case control study, which is I'm going to go find a whole bunch of people who have my disease of interest, a bunch of people who don't have my disease of interest, and look for differences in their exposures. To the cohort study, which is I'm going to take this whole population, assess their baseline exposure, right, make sure they don't have my disease of interest, and then follow them through time to see how those exposures might relate to the disease I'm interested in. Cohort study. To the randomized controlled trial. And I think, are you guys doing some kind of quasi-experimental trial? Your study? Yeah, for this?
No.
No, okay. So the kind of randomized, and you can randomize completely, like these people are going to be randomized to this intervention, these people randomized to intervention B, and I'm going to compare their outcomes. And then once that happens a lot, and you've got lots and lots of trials and observational studies, you can then do a systematic review or a meta-analysis, which is I'm going to take all of the research and put it together and see what my best guess is. And so thinking about like how you're going to design your study, you can think about which, and we can help you hopefully today decide sort of which study design or what your study design is, or what study design would be best for your But so this is what epidemiologists think. So a lot of people think epidemiologists count things, and in research we count things, right? We want something to count. We like numbers, right? And the things to think about is when you're counting things, you want to think about who and what you're going to count, right? So who is your study population and what you're actually going to measure, where you're going to find the things you want to count. Right? So where does your study population come from? When you're going to count them, so when in time, and I think you're all doing studies in present time and collecting information in present time. And then how to count them. And so hopefully we'll talk today about how you guys are going to collect information and the methods that you're going to use to do that. And then once you've done that, how you organize what you've counted in a way that you can look for patterns, right? And that's sort of your statistics. How do you organize your data so you can then analyze your data? And finally, figure out what those counts mean. And then you analyze your data and you figure out what does that mean in the larger picture. That is what it is. Okay. So basically what I thought we would do is kind of start a discussion around where you guys are with respect to choosing your study population, who your sample size is, and your sort of sample planning, if you're there, your study implementation and how you're going to implement your study, or if you've thought about your study design, what kind of design you're going to use and how you're going to implement, and then how you're going to collect that information, like questionnaires, interviews, surveys. So I chose like a random order that we start with, so we'll go through. You guys start. And sort of think about, like, you guys can kind of give us an idea, a little more in-depth idea of what you're doing, and then along those 4 measures, who you're sampling for. Does that sound good? Does anybody have any questions before we start discussing burning issues or anything? Does that sound good to you guys? Mm-hmm. Okay. Okay. So go ahead. So give us a general idea.
So the general idea, you're right, is the study population could be any parents that live in Delaware that have teenagers of any sex. So that's the big population for which we're drawing from. Yeah. And so that's a big population. We are doing 2 different types of surveys. So one is, the first is going to be the qualitative. And we're going to be doing focus groups. Originally we had 3. It looks like there's going to need to be more because we have to do downstate as well.
So
but
you're covering the entire state.
Yeah, we didn't want to, but
we'll probably focus on Newcastle County and Sussex.
Yeah,
is kind of what we're thinking.
Exactly.
Not to discriminate against Kent,
but just because there is different, like probably the most different ones were Kent. So yes, the Newcastle
and different with respect to their policies with LARC, or
to access is a big difference, and I think the populations rural versus urban are big differences, and so trying to capture, and then you have suburban in both places.
And also the teen pregnancy rate is highest in Wilmington and then in western Sussex County, so I think that impacts our decision too.
Okay. And that's for your focus groups.
So that's for our focus groups, is looking in those areas and kind of generating. As far as how we're going to recruit people from the focus groups, one of the things that we have designed our projects to do is to get community researchers on board with us. So we're in the process of recruiting community researchers and hoping that they would have the into the study population. So whether we're going to a Boys and Girls Club or a PTA meeting or tagging along to some other organization that already exists and getting a sampling of their parents. It's kind of where we're doing.
You're doing focus groups or key informant interviews or both?
We're probably going to do some key informant interviews too. Like I was planning on in this class, but I was planning on doing kind of just interviews in general, but wasn't planning on putting that in my study design. But after kind of the talk we had on qualitative methods, we're going to incorporate the kind of interview part of the study design. So that's kind of the first part, and then the second part is a survey after we kind of have the focus groups and figure out what parents know and don't know and how they feel, generate a survey that we can get to a larger group of parents perhaps using the, I work at Nemours, so the Nemours database of parents with kids over the age of 13 that were seen last year and sending out electronic surveys to them is one.
And that would be state-based?
That would be, so that would get the whole state. So we're trying to figure out a database that would get the entire state. That's kind of...
So, I think last time we had a very intense.
We did. That's why I was scared to like. I think I forgot about that with the yes.
Right.
Right. We
and
did have
these issues in your study population.
I think that we would go for a higher number in order to be able to get those subsets. So there was a debate about whether we should just do mothers. And exclude men or exclude grandparents, and we felt strongly that we didn't want to exclude anyone, so that means it's going to increase the numbers of people we need to sample.
Yeah, so I mean, it goes back to like, if you use the Nemours database and you're sending it out electronically, so people you have email addresses, do you typically have both parents in the database or just one, and does it tend to be the mother, do you tend to have a grandparent's email address? That may limit who you send it out to.
Right.
Well.
Whoever is the guardian, the email's in there. So it depends if it's a dad-only household, then it'd be the dad, or it depends on who.
So this is going to go out to the guardian that's on record.
Right.
And that may be mother, father, grandparent.
Right. Foster parent.
Foster parent.
But if you have more than, how many of them? If you have a two-parent household, how many of them have both email addresses? You only have one. Does it?
Of course, it tends to be the mom. It does.
The mom, or is it the primary insurance holder?
It's the mom usually.
Typically
Who comes to the appointment?
Well, who has the email in the system? I don't know when they send, the access that we get, what that would be for, but I would assume it would be the email that's in our system currently, which tends to be the mom.
Person who's coming to the appointment, bringing the child,
right.
It seems like that's like the right.
Right. And so that's kind of where we're at.
The other thing I was going to say is in terms of practicality of getting those emails to the people, is this something that Nemours is regularly emailing these parents about, or are these all going to end up in people's jobs that they may or may not look at? Because if they're not used to getting those emails from, they not actually.
Yeah, they get lots of a lot of stuff. If you leave your email address, you'll get contact through email. But that's just kind of one way to get the state database, and that's what there's another research group that kind of did a similar study in how they recruited kind of a larger random population through the hospital database. So it's kind of mimicking what's already been done.
Do you know what kind of response rate?
I wouldn't say it was maybe 50 to 60%.
So and what does Nemours covers how many, what percentage, say, of
it's the
13
only
to
children's
18?
hospital system in the state, big major system, and I think something like 70% of kids are touched by Nemours because they have primary care and specialty practices in the ER and the inpatient, so it's a big chunk. We were to go
downstate.
Yeah.
And to access LARC, do you have to have insurance?
No.
To come to Nemours, do you have to have insurance?
No. You just can't have United Healthcare insurance. So, which I hadn't thought about, that might. But again, it depends on how you do it. If you capture inpatient and ER visits and other things that aren't.
So you'd have emails for everyone, not just.
Yeah, it would be any.
You said you just can't have what?
You can't have United Healthcare insurance right now, but we still see those patients inpatient in the ER. So that's something interesting that I just thought about as you said it. That if we were to look at only an outpatient, that would exclude a big chunk of people.
What do you think about it? And so so how many people would that be? Your target is?
So
70, I don't know, you couldn't even guess.
Our original was about 100, but again, if we want to say something about the smaller groups like the men or the grandparents, then we need to probably have higher numbers.
Oh, right,
with that.
because you want to look at subsets, is that?
Yes, we do. And so if, in order to capture that, we're going to need to have higher.
And in your focus groups, you're going to then
Focus
try
groups
to
are going to
target
be small, so
those
we're going to be targeted.
subsets,
So,
like
right.
a group of men, a group of grandparents.
The original design of the focus groups were based off of race, because one of the considerations we had is that a lot of times efforts like this in the past have been seen as stigmatizing people in drugs or poor or minority, like you shouldn't have babies, and we wanted to make sure that we're getting kind of that sense. So we weren't thinking like mother-father differences, but more kind of race differences. And so we were planning on doing kind of a Latina, African American, and Caucasian group were the original ones, and then somehow we're gonna have to add Sussex County into that milieu as well. But obviously the focus groups are smaller, so we're talking about
And then you're going to use those focus groups to design
the questionnaire. And there are some questionnaires that sort of target some of the areas that we can use questions from those previous published questionnaires from, so it wouldn't be completely. But because we have a starting place, but because we're focusing on Delaware and issues in Delaware, it's going to have to be some new questions that we're going to have to add about stuff in Delaware. So
your target of 100, you're going to add like 2 zeros after.
We'll have to sit with our epidemiologist and talk about
that was our discussion last time.
It was at the discussion last time.
Yeah, because we tried to explain that would require a really high sample if there are subsets.
But you might get more than 100 if you are projecting that you'd get a 50 to 60% response rate, and Nemours covers 70% of kids in Delaware. So I don't know how many kids are between the ages of 13 and 18 in Delaware.
For adolescents in general, it's about 120,000 adolescents.
120. So if half of them are, say, even 50%, that's 60,000.
Yeah, we have plenty of numbers to draw.
You'd get 30,000. Are you thinking of sampling your email list or sending it to all 60,000?
No, probably. So what if majority of them that answer are mothers? Then you don't have subsets unless it's targeted, right? And you're going after grandmothers. You're going after. Because you may end up with majority of the respondents being females, or mothers.
Right.
Sorry.
So the survey that you've done that, there haven't been many that have done anything like this, but the group that did it before, they did telephone. They targeted the hospital, but it was like maybe 5-7 years ago. So they did telephone interviews, and about 60% were mothers that answered the phone in that group. But 40% were not.
I guess my question, I thought you just said, though, you weren't going to try to compare mothers with fathers with grandparents, but rather the different racial ethnic.
So the original intention was the racial ethnic groups were the comparison. But then it brought up in our class 2 weeks ago that what about, are you only going to target mothers, or are you going to do all parents regardless? And we wanted to do all parents because it's a lot of times it's grandmothers are making these decisions and mothers, but then a lot of times, fathers make them too, and we don't want to exclude. Or they'll say, like, I need to go home and talk to my husband, or, it's okay, but let me talk to my husband first, or talk to her dad. So I think if we only target mothers, it's going to be hard to make generalizations about stuff because they're just one component of people that make the birth control decisions for teens.
Well, but the question I think comes to, you can send out a broader sample, but then if you're going to try to compare, how do mothers respond versus how do fathers respond? That's different. You may not have the appropriate sample of the non-mothers to really be able to make those comparisons, but it doesn't mean you need to exclude those groups. You can still include them, but you're not going to be able to say much about it.
Right. And it's fine. I mean, I don't really think that there's going to be a difference between too much between mothers and fathers. Again, looking at the other stuff that's been out there, they also looked at stuff that we didn't think about, religion and socially conservative, like political beliefs or other kind of things that they kind of stratified things for. But the things that made a difference seemed more to be along education and relationship with their independent, like things that were not racial or.
Yeah, what we suggested is to really take this small subset and make statistical comparison if there are any statistically significant differences between mothers and fathers, and if so, then they have to be excluded, because then you can mix pears and apples. That's what I was saying, and that's kind of where we ended up. That initially you're going to collect all of it because that's really where the data are, or the decisions are being made, but you'll have to make comparisons to see if you can mix the subgroups.
And I would think, I mean, I don't know, but in the focus groups, like if it comes out that partner is, you know, has an influence or whatever, that would be part of your question. So you could then look like, you'd have a question like, my partner influences, and then you could look at moms whose partner, dad's partner.
Exactly.
You know, one way or the other.
It can be basically prevented, this.
Yeah,
at the focus
into it with the question of
exactly. Is there a difference already at the qualitative level, at the using qualitative research? Is there a difference? If you don't see a difference, still you have to do the comparisons. But you at least prevent yourself from, you know, collecting all this data and then throwing it out if there is a difference between those.
And in your study implementation of your survey, so it's going to go out on email.
Theoretically.
For those that have an email, right? So your population is really like someone who comes to the Moores with an email address or a valid email address.
Mm-hmm. How does that bias yours?
I mean, there's always a bias, right? And then they have to respond to the email and all of those things. But pretty much everybody has an email address. Like, that's something that's captured as part of demographics for all encounters.
But do they have access to internet? The low socioeconomic groups, do they have access to internet? That would be my question. Do they regularly check internet? Do they have time?
No, checking your email is a whole other thing. I don't check my email. But
so how do you make sure that your group is represented? It's really representative, and you're not really just pulling out people who actually regularly answer email.
Another thing too, I mean, I work at an HIV clinic downstate, and we've been really focusing on getting people in our patient pool, and they have to have an email address, and there's a fair number of people that don't. That don't have access.
And they would be making decisions.
Lower socioeconomic status, you're really kind of biasing. Relying, just like, you know, all the telephone surveys, you know, exclude people with cell phones only. You know, it's a bias, you know, and that's a different population.
And I've seen, like, I'm surprised, you know, in my patient population, although it's small, I would have thought only my older patients would decline, but I'm getting, you know, I still get, you know, people at all ages. And well, anyway, it's a whole other side issue, because Christiana has some weirdness around kids signing up for their own email communication.
But we're doing parents. Yeah.
And I think this is an issue, what we're talking about now is an issue of what's called external validity or generalizability, right? So who can you generalize those results to? And are you comfortable with the fact that you might just be able to say, these results will apply to the population that, you know, has an email, has internet access, and comes into the Moore? Like, if you're okay with that, then you just have to know that that's the limitation of your study going into it. Otherwise, you're going to have to change your design.
Or, you know, you can always supplement. You know, we've actually had some, you know, colleagues of mine have had some experience with email versus paper surveys, and what they're finding more recently is that the response rate for paper surveys is actually better. People are getting emails up the yazoo, and they're tired of doing all these surveys online. So you just might want to think about, you know, you may want to start with email, but see what your response rate is, and if it ends up not being the 50 or 60 hoping for, what are some other ways to supplement? Is there an adolescent clinics that you could distribute papers? I mean, mailing obviously is quite expensive relatively, but you know, you might want to see other ways that you can augment your sample.
That changes the randomization. So one of the reasons I was looking at
Well, you don't have anything randomized.
Well, you don't have randomized.
If you're doing random sample of the, you know, I want to get a random sample of the people that are in the Moores, like that's what we're looking for, a big population.
You mean the
does.
ones that you send the email to?
Right. That's
No,
what I'm talking
Marcy said, you're saying, so you have your random sample, here's your people, and now you want to make sure that they respond.
Right.
So they're gonna email you, and those that don't email you.
Yeah, we can send a paper
You can then
or-
send a paper to,
yeah,
but that's still
yeah.
your random sample.
Yeah, that's what-
It's not like you're gonna go get somebody else and be like, oh, look, they're doing paper.
But no,
That
when you're
would-
saying using the adolescent clinic, then you're talking about the people that are
Yeah, that
coming
would
to
be
my
different.
practice. That would be
Right.
different.
Because I didn't know you were
That's
saying,
why-
I didn't pick up on the sampling. I thought,
Yeah.
since, I mean, email is free, so is there any advantage to sending it to everybody?
Yeah,
To everybody,
like why
yeah.
would you sample and not just send it to everyone? Do you, I don't.
Is it too large of a?
Yeah,
of
it's
a-
too large because
50,000
it's gonna be
like-
like 50,000 people.
You
to
send like a blast
a
out.
blast
Too
out,
big?
out too big. Unless we narrowed it and said over like everybody that came in the month of October or something like.
That might be fast.
Yeah,
And why is it too big? I mean, I don't.
because there's a lot of patient visits throughout
So
the
it's
whole
an
ward
electronic
system in
type
Delaware.
I guess, you know, if there's a way to sample the database where it automatically populates emails, then it shouldn't matter how many emails
You send
This
out.
is an electronic survey, right? Like
Mhm.
you're gonna send an email,
Mhm.
they're gonna link, and you're gonna have some system where they type everything in.
Right.
Right, so it's electronic.
Yeah, be right cap. Yeah.
or something.
And are you physically typing in people's emails, or is it a system that can look up everybody's emails and send?
Yeah, it wouldn't be us physically typing.
That would be in a spreadsheet,
yeah.
right? Excel
Yeah,
spreadsheet
it would
already
be
coming
however-
out. So,
yeah.
so you could send it to all of
We
them.
could send it to 50,000 people if we wanted.
Yeah.
Why not?
Yeah.
Then, you know, you get a
Yeah.
50%
Well,
response rate.
especially like you're auto-populating it to
Exactly.
a database. There's, you know what I mean? Like the amount of work doesn't increase exponentially, but the power of being able to draw conclusions, for instance, about populations
You're
would.
better off for publication too.
Send it to
Saying
everybody.
that you send it to everybody at the.
I mean, I think the only downside is if you send it to 50,000 people and get 5,000 responses, you know, whereas if you're able to somehow, I mean, if you're just randomly sampling, that probably doesn't help you. But if you think like there are email
Most
addresses
people
in
go
your
down.
system that aren't active really because they haven't been seen in
Mhm.
3
Yeah,
years,
yeah.
then you wouldn't want to send it to those people
Well,
because that's
then
just gonna.
there's a
might
way to do
reduce
you send an email, would you be willing to participate? There are ways to actually reduce your sample, the response, or increase your response by doing an email first, and so that the email is really active and the person is on there, so your response rate is better. Once you get that response, you send them the survey rather than sending it without knowing if the email is really functional or active or whatever.
Yeah, 'cause it's relatively hard to publish survey studies with.
Yeah. So
Definitely.
sending that email first might prevent it. You still have to report that how many people it was out of, but it would be better to say, you know, of the people that responded to my invitation, this many, 70% responded with the survey that I sent them, rather than having 50,000 and waiting
Right.
I mean,
without
email
knowing
also-
if they're really active.
I mean, email also sometimes say, you know, report back to me when the email itself is opened. So you could, you know, that could just be automated as well. You could know if the email is even opened. And that might give you
There
some
is ability in
information.
the survey to see if it was even started or if it was open.
Or maybe it is like those that have come in the past 2 years, or
Mhm.
what's the
That's
recommendation
what
for
I
an
was thinking.
adolescent to come to every year for 2 years?
I mean, this is not just primary care. This is anyone in the hospital. So that would be ER, inpatient, orthopedics.
So here's my pragmatic concern
Mhm.
for you. Do you have anybody, like, is your hospital from IT who's going to support this kind of stuff? Because, I mean, I'm thinking, like, you know, to say to the hospital IT, give me a long list of email addresses, that's one thing. To ask them to help you set up a system where you're tracking people opening emails and stuff.
We work with a really good system, Qualtrics.
It's
Red
like
Cap.
Red
I mean,
Cap.
the
We
question is
can-
getting the
we
email
can-
addresses versus sending out the survey. The survey would be through Red Cap.
Right.
Yeah, and
Oh, okay.
We
Yeah.
can, yeah, I mean, Red Cap has all the abilities of doing this type of thing.
Red Cap's at Nemours.
Yeah. No, we have Red Cap. Oh,
So
okay.
Red Cap
And
can
there
do
is-
the
and there is
email
understood.
tracking, it can track
I think
people's-
so.
Oh, okay.
And there is a really very good group at Nemours that, you know, that is
Okay.
taking care of Red Cap.
There you go.
get on their radar like soon?
I mean, it's such a,
That's
I would have been.
Oh,
Yeah.
Huh?
See, they don't need us.
But the IT at Nemours would have to be
Yeah.
able to square,
Right.
you know,
Right.
visits within the last whatever amount of time.
Right.
You know. So
With
like I said, you wouldn't want to
Age
just
group
do
of
all visits.
Yeah.
children.
Right.
And that's your quality control measures, is then like making sure that the emails that come in, that you sent it like 3 or 4 times, that they're valid emails, that they're all that kind of survey has within it, where they have to or answer questions or have to at least answer a certain amount of questions. I don't know.
Right. I think Red Cap can do lots of stuff. And then it's gonna, I mean, we're reimbursing people, so we're gonna have to cut it off at some number.
Oh, you're reimbursing people?
Oh, you're reimbursing people?
Yes.
Oh, that.
Oh,
Yeah.
there you go.
So, have to cut off after a certain amount.
You can even say that first however many respondents.
Yeah, I mean, that's all the surveys I fill out.
Get a
is
little
ones that give me
bonus.
money, so that needs to be in the title.
It's in the title.
I said, those are only surveys I fill out, are the ones that say they're gonna give me money, so that it
Yeah,
would be in the
you're
title,
right.
like $10 if you
Just
complete
like
the 15-minute survey type thing.
And obviously the question then is how does that bias?
Are you gonna give them money for responding?
Yeah, I think we had like
And
a
that's
$10
your
gift
problem
card or
with
something.
having too big of a sample.
Right,
I mean, if
right,
they're
you
paying
can't
for,
hand.
you didn't mention why it wouldn't be. We don't have the budget for it and have
Yeah.
to randomize.
Yeah, then you might want to
So it's smaller. Yeah.
How are you gonna give the money?
A $10 gift card, so probably like the Amazon.
Are you gonna
like
email it? Then you're
electronic.
getting into a
You're gonna
problem. How
email
you're
it.
gonna mail it? Are you
Yeah,
gonna email
probably
it?
like the Amazon email.
But then you're
$10
gonna
cards.
basically, is that gonna be anonymous or is that gonna be, you're gonna know who responded? They're getting into an issue of knowing the respondent's email. How are you gonna link that? How are you gonna have
I
it?
don't know.
Okay, there's a pretty.
I think so the way we do it, like at the end of a survey,
They can put in.
you can put like put your email or whatever, and that goes into a separate file from the data that you're collecting, and so you just send the money to that file, and
I find a way to link.
Can't link it.
I find a way on Qualtrics.
Yeah, well, you can't link
Yeah, I
it. You
don't
just
wanna
send the
link it.
$10
Yeah.
to the emails that at the end went to file B, and then the data is file A.
Yeah.
You know what I mean?
Yeah.
Yeah. And this way, you protect confidentiality. Right? Do you guys do that?
I mean, I haven't done this before, but I've participated in, which is why.
Yeah, and then your confidentiality is protected so that the person.
Not on
so that
Qualtrics.
the
I found a way to link these things.
Well,
I'm not supposed to, but there's a way to link it. That's the problem. They don't know it at IRB.
I don't know on Red Cap.
Yeah.
Well, with Red Cap, I don't
Don't say
know
that.
if they
You're
would
being
either.
recorded. I'm just kidding.
That's their problem. They need to fix it.
Yeah.
I sure as heck
It's
wouldn't
not my
figure it out.
problem.
I'm not worried about
Red Cap probably has. I think Red Cap is a little more sophisticated than Qualtrics is. The Delaware people like to use Qualtrics, although the University of Delaware through the CTR has access to Red Cap, FYI.
Oh, I didn't know that.
And Red Cap I think is a little more sophisticated. That'll be good. Awesome. Good. Exciting. And your time frame?
Time frame for.
For like from focus group to survey, and then what's your general time frame? You haven't started your focus groups yet.
1 year to do the project. The thought was the focus groups would start in the spring, and I think we had in our timeline in the back to school time, like August, September-ish.
To do the emails.
The
People are back from summer and
yeah, I think that's.
they're getting school emails, so they're ready for emails.
Right.
That's good. Good. Great.
So we'll see. We have to recruit community investigators first.
You have to recruit.
Community investigators is part of our project, so that's the first step.
That's the beginning part.
Yeah.
So you get the... Okay, I think this is Omar, right? Can he see? Can you guys see the slides?
Unmute.
Yeah. Omar, can you see the slides?
Or Michelle?
Hi, it's Michelle. I can see them. I'm not sure if Omar can or not.
So we were gonna have you guys maybe just give us a little summary as to like your study population, your sampling frame, and then how you're gonna implement the survey.
Certainly,
I'll
I'll start.
Is it paper or what kind of information are you collecting?
Okay. Omar, please feel free to jump in since you have a much longer history with this than I do. But essentially, we are looking to recruit in North Charleston, and there are 7 neighborhoods there. So we were looking to recruit 300 participants to complete a survey, so about 42 from each of the 7 neighborhoods. And we have some community partners who will be going out and recruiting, doing the informed consent and collecting of a paper-based survey. And that survey is collecting demographic data about the individuals in the community, and these would all be persons who are at least 18 or older and have lived in one of these 7 neighborhoods for a minimum of a year. So we're collecting demographic data about their health history, their family health history, health habits and behaviors, and also perceptions on the toxins and proximity to toxins within the environment. And then those data would be entered into REDCap. So that is our plan on that portion. And then there is also a component where we're doing visual mapping of using spatial statistics on the neighborhoods and what's available for the pollution in the area using GIS and interactive mapping. So there's 2 components there of this. The neighborhood, LAMC, the community organization that Omar is involved with, they already have done research on environmental justice using an EJ radar GIS mapping system. And I will be getting up to speed on that system. I am familiar with GIS mapping and have already done mapping on food deserts in these same neighborhoods, but I've used different software for it. So that's what we're doing for this component of the study. The survey is in development right now. Omar and I are working together to finalize the questions, and there are quite a few questions, and Jamel drafted this with the community partners' input already, and they are taken from quite a few different validated surveys.
Just have to move. Did I do that?
Everybody stand up.
We're too still.
Yeah.
Every 30 minutes, people have to move.
Well, that's good. That's actually not bad, right?
That's not bad.
I know you're gonna stand up. So what? How did you come up with that 300? That 42 people in each of the 7 neighborhoods?
That would have to be Omar who would address that, because I was not involved in that decision making. Omar, are you on?
I am. I'm here.
I'm not sure what the background was. Jamel and Omar worked together on that component. So I'm in the process of transitioning here, but they were the ones who determined the 300.
Can you tell us,
For
like,
the sample
how
size.
you...
There was a formal sample size, I mean, I remember from the protocol.
They did. And how are you defining neighborhoods?
Okay, so we define the neighborhood based on the closeness to the activity. So that's the port and the intermodal facility, because basically we want to use this information to be able to include in the intermodal facility, in the EIS, the environmental impact statement for the intermodal facility. So we want to include those communities that were close to the activity. So that's going to be Socorro Cherokee, Union Heights, and Applebee's community. So what we decided to do was to take approximately about 75 individuals from those communities to get a good baseline of the impact on people's health. So we want to get a baseline of people's current health. And I believe Dr. Ellis got that sampling size recommendation from a statistician from MUSC.
I do believe she worked with the statistician and also with Dr. Vina here at the public health program to design that. And if I remember correctly, there were about 8,000 residents, like individual residents, and like 1,500 households within that community.
But
Yes.
you're sampling, so individuals, each individual is living in a separate household. Does that make sense?
Right. I believe there are approximately 1,500 separate households.
And your target is like an adult?
Yes.
In each of the, so an adult in each household. You wouldn't have like an adult where they're living in the same household, right?
Well, that actually should be clarified because as it's currently written, it just indicates 300 adults. But yes, we should specify whether we would be recruiting more than one per household or not. I'd be inclined to say separate households, but Omar, obviously, I need to know what the community wants and what you all think too for recommendations.
Sure.
And how are they, tell me again, how are you recruiting the individuals? Like, are you going out into the community and asking people to participate in your survey, or you're using these community organizations?
So this is a discussion that we had a while back. We technically were going to do so what we decided was in our community, we found that door-to-door works best. If we're going to do some door-to-door surveys, and then that was an idea that we kicked around about maybe even going to the local barbershop and hanging up flyers there to recruit people that's in those communities to participate in the survey as well. So it's going to be a combination of going in those communities, door to door, doing this, as well as recruiting areas that people frequent, like beauty salons, barbershops, libraries, those types of areas.
And how much intermixing do you think there is in individuals, like from neighborhood to neighborhood? So, you know, would someone from neighborhood 1 go to a barbershop in neighborhood 2? You know what I mean? Like, are they that close, or?
There is some intermixing. Yeah, you can definitely have that to occur. We also, I think that we talked to Dr. Ellis about identifying, somehow coming up with a way that we can identify individuals by neighborhood, making some type of code or something that we can do to identify each individual from each neighborhood, being able to do that. So we haven't really given it any kind of good thought about how, but we did have that discussion.
Because I'm assuming, like, whoever did your sample size estimates, they really depend both on, like, the total number of people, but the number of people per neighborhood. So you want to make sure in your sampling frame that you have the 7 neighborhoods and the 42 or so people within each neighborhood, that it's not, 100 from neighborhood 1 and 5 from neighborhood 2. You have balance.
That's right. So what we decided is that we're going to have 75 from each of the neighborhoods that we target. So I believe that we said we're going to do 75 in Union Heights, 75 from Socorro Cherokee, 75 from Acadie, and 75 from Roosevelt. So,
Are you going to get sort of where they reside and also where they work? Like, what if they work closer to the facility than where they live?
right, we did not go that far to include that information. Right now, from the discussions we had, it's only where they live. Now, our community group, CCRAF, which is the Charleston Community Research and Action Group, we are currently working on a grant proposal where we are looking for funding to purchase personal air monitors, where we're going to be asking members of the community to wear these air monitors. We could track their movement patterns from, daily, normal daily activities of where they work, where they go to corporation, church, and we're planning to sample those acts. There's kind of a personal airspace. Sample that personal airspace every 10 minutes, I think is the interval. So we'll be getting some data that way as well.
But those personal air monitors, you're saying, have like a GPS system, so it tracks every 10 minutes and it'll know where people go, so in and out of different areas. Right, it's nice.
It does, and it automatically uploads to a it's a website-based data storage, so it can automatically update to that. And what we plan to do is take that information and download it to our EJ Radar, which we developed to kind of be a community engagement, community empowerment tool where community members can actually access the data and be able to map particular areas that are concerned to them, and they can use that information to advocate for better policy. Particularly what we are talking is not only better air quality, but we're also targeting better zoning policy. So we're going to be targeting the city of North Charleston to change their zoning in a way where our communities are not always the communities that are overburdened by negative polluting industry. So we're going to do to be able to change that policy and promote better zoning regulations.
And is your survey, are you going to ask the people that participate if you can contact them again?
Yeah.
Over time, so it's the same people that you have baseline health measures for, that you can then, when you get these personal air monitors, that you can track the same people?
Yes, we've actually included that in the consent where we're asking if we can follow them up, because this is something we'd like to look at longitudinally, is to have this is the baseline, but then be able to continue to monitor and record what's happening in the health of the community.
So that was this, Marcy. That was my question as well, because you're going to have your baseline assessment, and then this big construction project's going to happen, and then at some point in the future, you're going to do another assessment. And is it the exact same people, or are you just going to do the same communities?
No, it's going to be the same.
Yeah, because if it's the same people, that gets a lot more complicated, right? Because when you find your initial random sample, you're going to want to assess, like, if they have any plans to move out, to, which they may or may not know at that time, and so you're going to have to account for some loss to follow up, right? Because people move.
Is it a pretty stable? Are they stable community? Like, do people move out and in, or?
It is a pretty stable community. The only thing is that with this intermodal facility that is coming, 300 homes are going to be impacted. So that means that they are going to be displaced. 300 individuals in the Cherokee neighborhood are going to be displaced. So we're working on a mitigation to get those people relocated in the same neighborhood, which is going to be difficult because the housing stock is not suitable to kind of accommodate that many people moving at the same time. So we are.
Your microphone's fading out. It's hard to hear you.
Oh, I'm sorry. We will be losing some community members in the Chicora Cherokee neighborhood when the intermodal facility is built. They plan to relocate 300 individuals. 300 homes are going to be impacted.
So how far into the future is your planned follow-up assessment?
This project is a year, so I plan, at least my understanding is that we're going to be working with other groups as well. I know that University of Maryland is very interested in what we're doing, and we are working with them on some other things. So they want to come on board as well with some continuous health surveys as well. So we have different groups that are interested in different things that we're doing. So there is the possibility that there will be a lot of overlap with projects that we're going to be working on. So this is going to be something that we hope that from year to year we can continue this type of monitoring and sampling.
Right. So I think, if you have a sample population that you're following longitudinally for a year, that's one thing, and that's relatively feasible. But, if you think about like the effect of diesel fumes, it's going to be a long-term effect, right? It's going to be, you might want to know what outcomes are in 5 years and 10 years. And following those same group of people for that long is going to be really challenging because people are going to move away, they're going to die. You don't have a huge sample to begin with. And so, you might want to think about, like, this could be basically a cross-sectional survey where you're sampling this group for this period of time, and then, in 2 years or 5 years, you do a similar sample, but it's not necessarily the same people, but it's the same communities. That's what, NHANES, is everyone familiar with NHANES? Mm-hmm. It's, National Health Assessment Survey, so they do a statistically valid sample of the U.S. population every year to see, like, height, weight, blood pressure, all these lab tests, et cetera, but it's not the same people every year. That's how they make national estimates of obesity and all these other things. So that might be something you think about as opposed to trying to follow the same people for more than a year.
Gotcha. Understand.
Or you put your resources into trying to follow these people, because with the same people, you really can then say what the impact is on this intermodal, on this facility being built. Right. If you have their measurements over that time period. I just don't know, like, what the time frame is for this facility. Like, so if it's 10 years, then that's going to be hard. But if the facility is going to be built within 12-month or 6-month, 12-month period, and there's, you have a relationship with these people, that it wouldn't be terribly difficult to follow them?
Yeah, we do. We actually have a good relationship, rapport with the community members. This facility is going to be built, I believe, by 2019. The port is going to be built by I think they're going to try to have it up by 2019, and the intermodal facility is going to come online at the same time. So we're talking about within the next 3 years, 3-4 years, that this facility will be operational, both of them.
So, I mean, if you want to plan to then survey the same people again in 2020 or whenever, obviously that'll need to be part of your consent now, like you talked about, but also you might want to assess now for people's intents to, move away or change jobs, things like that, just so you can kind of exclude those front that you're not going to have that long-term follow-up for.
Right.
And was there any thought to taking any, like, clinical measurements? Like, I don't know if you have the finances, but like a blood sample?
I know we discussed that when we had the original NIH grant, but we just didn't have the funding to do, like, biomarkers and things like that. So I know that I'm talking with Dr. Wilson with the University of Maryland to do some additional studies to look at people's urine as well as blood work and do some different kind of biomarkers. So we have discussed that, but nothing concrete has came out of those discussions yet.
The other thing too is you can always try to obtain samples for a minimal cost if you have a way to store them, and then try to achieve funding for the actual blood tests later on.
And there might be
Yes.
storage at MUSC, or I mean, you might have a little bit of storage space you could find.
I
Sure.
can check into that.
Air samples.
Okay.
Do you have other questions, or that sounds good?
I don't have any other questions at this point.
Hey, Terry and Eva, you're on. Eva's on.
We got it.
So, our objective, as you have it there, is to assess the effectiveness of the system of least prompt combined with video modeling in young adults. At the moment, it's going to be actually before 21 years of age, because we have already selected a sample. We have we have targeted the agency that we are going to draw the sample from. And we're not going to do at the moment concurrent to single subject studies. Instead, we are going to do just one and follow up with a control with another study that's going to be group design, just experimental control design, experimental and control group design, basically comparing if there are differences. But just start with that. The moment we are looking at
But this isn't randomized.
No,
This is just the group.
No, this is because we really have to develop the research protocol, and we need to know the nuances of how the population responds to our intervention. We want to start with just a single subject, multiple baseline design with 3 groups that are going to be staggered, and they will themselves be their own controls. So only and only when they receive intervention, they will improve in their performance, and that will be staggered across basically 3 groups. So there's going to be one group 1, 2, and 3, and they're going to be introduced to the intervention at different times. And if they're introduced at different times, they start in the baseline, all 3 groups, and group 1 is going to be in the baseline for about 6 sessions, and after 6 sessions, we're going to introduce the intervention. Then group 2 is going to stay for about it depends. There needs to be stability. It all depends. That you can't predict how many sessions they're going to be in it, because that's not how single subject design works. So it's about 12 sessions. After 12 sessions, as I said, the second group is going to start the intervention. And then there is a third group that's going to receive the intervention after about 18 sessions in the baseline. And if all 3 groups only improve their performance during the intervention, then you have enough of evidence that this was effective.
How many are you going to have in each group?
2.
So 2, 2, and 2.
2, and 2. So that's kind of where we're going. If we lose participants along the way, 1, 1, 1 is enough for single subject design.
Just have 1 in each group.
Planning on doing it we already have RB awaiting final edits to get it approved, and we're going to start in January in about 2 weeks.
How long is the session? So the 18
session is about 15 minutes long. Okay. It's a very quick session. We'll supplement it. I have interns that are going to be working with me as the instructors, providing instruction to the population. We know the population because we have worked with them every Friday and at the Carpenter. So those are actually students between 18 and 21 years of age that are in kind of a training before they leave school system. And they're going to be going from Leonardwood to the Western YMCA, which is walking distance, and my interns will be working with them. And as the design goes, we'll be looking at, I just want to make sure I say it right, we're looking at the percentage of exercise steps completed independently in each. There will be 2 muscle strengthening exercises that we will task analyze into steps that the participants have to complete. So imagine a chest press and leg press. Those are the 2 exercises. They will be task analyzed into steps, and the percentage of steps completed independently will be basically the success of the intervention. So the less prompting we have to provide, the more successful the intervention is considered. So the idea is towards the end, because that's going to be a curve, for them to complete the task completely independently with just video modeling, which is the video that is going to be presented, where the steps are going to be presented to them. I don't know if it makes sense, but
so the 18 sessions prior to the intervention, there's no video modeling.
No.
And then the interventions really is bringing in this video modeling.
Correct.
And then to see how
long it takes for them to complete all steps of the task, which is the exercise, with very little physical and verbal prompting, with just the video, because the idea is for them to be independent in the gym with just the video prompting. So if they go to the gym, so that's the final product of it. Right. They only need the video to exercise on the machine, without anything that would be obvious to the non-disabled population, so that they're not physically assisted by someone. So in order for them to be fully included, the idea is that they come to the gym, they have an iPad, which everybody else is wearing and coming to fitness center with, and they, with headphones that are wirelessly connected to the iPhone, to the iPad, will be following the steps. Because nobody knows really what's on the iPad, they will not know that they have a disability and don't know what to do on each of them.
And why do you vary like the 12 sessions, the 18 sessions? What's the purpose?
Because we need to establish that only the treatment, it's just like the control group.
So that's the control period?
Yeah. So if only and only there's going to be like this improvement, this improvement, this improvement.
Right.
If the improvement only happens when intervention is applied,
right,
then, and that is staggered basically time-wise, then you can prove that using or following the rules of a single subject design, multiple baseline, single subject design, that it is actually effective. So it needs to be staggered in order for you to eliminate any confounding factors. If it was all done at the same time, then it can be that during the time there was something else that had improved their data. Like it might have been just a simple learning, right? It could have been anything. And the fact that you have them staggered time-wise eliminates these confounding factors, makes it much longer and very labor-intensive. But it actually, I've done it twice now, 2 years in a row, and it's actually pretty effective. When the subjects are different, entirely different in their abilities, it becomes a problem, because simply sometimes because of their abilities, cognitive abilities, it changes. There are different performances.
So these 6 subjects will be similar
in their cognitive abilities.
To recruit them in such a way.
And it makes it harder to recruit, but in the group design that we are planning following this particular single subject design, there will be a wider variety of their cognitive abilities. We'll have to, because we won't be able to find as homogeneous of a sample. This would
But that would be a different design.
That's a different design that we will follow after this study.
Just to get
hoping using this funding still. It all depends how well this project goes, where we go with it.
And are they all going to have the same intellectual disability? Like how similar do they need to be? Like
Similar.
size, gender?
They're gonna be
age,
the gender
cognitive
really.
ability?
I don't think there's that matters. I think the studies that I have done do not indicate that cognitively they are different by gender, because at that age that doesn't. I mean, they're already young adults. Children, it might be different. Yeah. But with young adults, the gender differences go away. So there is not. I don't think that's an issue. We're gonna have. I think majority of looking at it, we might have a good balance of females and males, and if possible, we would put one male and female in each group. But that is not. I don't think that's a requirement for single subject design. Once you have a group design, that's a different question. But even then, this population is so small that if you start picking into and going into these groups, as long as you have, like for the group design, as I said before, looking at where are they statistically different. And if so, then there's another study to do that. But it's not our problem at the moment to look into gender differences with that age group.
I think that's where I was a little confused when I read your protocol, is that you talked about randomly sampling these 6 people, but then also wanting to have, gender and racial ethnic diversity.
Yeah, but that was
6. That's really hard.
Yeah, for NIH, we'll have to make sure that they're representative. Yeah. But we're not going to do for NIH. We're not going to do single subject design.
You're selective sampling here.
It's not really.
It's selective. That was a mistake that I wrote.
Which makes sense.
It's not really random. It's our own randomization into which group you put them in. But even then, it's selective, because if we were to have only girls, then yeah, we can maybe the same ethnicity, then we can randomly put them into groups. But it's going to be their schedule. It's going to be it's going to be a lot of factors they're going to play, and so it's not really random. That I would like to take out of the proposal. That was definitely one thing that was an error in the proposal. Yeah, it's not going to be
random. You're going to try and get them as similar as possible.
Yeah, there's going to be more of a
gender won't matter, but at least some other factors.
Purposive of a sampling. It's going with a purpose. We're going to go more. It's not really convenience. It's more of a with the purpose. We're going to be putting them in those groups. Yeah.
Does engagement matter? Some folks are more engaged. Are the people who basically do this, is that kind of taken as their level of engagement? Because
we initially were looking at. We were gonna do their eye tracking, and we still might do that, to put eye tracking glasses on them, and we're not there looking at the iPad. So that is still a thing that we might add, but that is something that we need to discuss at the moment. We might not do it for single subject design. We might do it for the following design. It's just eye tracking device we haven't tested, and we don't know how well it's going to work with in that population. It's going to definitely make them different from everybody else, because they're going to wear it. And there's just so much more to it.
I guess that because you're sampling over a long period of time. Like for instance, sometimes I go to the gym.
Yeah.
So I'm going through the motions. So
but we will be recording them, we will be recording their performance, and that's going to make them different as well. We're just afraid that the glasses is going to, since they're such a sensitive population, that's going to make it hard for them.
The recording is in the device, is in the iPad, or you're recording?
The recording is going to be outside camera.
Oh, okay.
We have to do outside camera for analysis of the steps, how many steps they completed. But with that, we in the previous study that we did, we were able to track their eyeballs, but it was difficult at moments. You can imagine. So having the eye tracking device would help if they were looking at what part of the iPad they were looking at, which part. So there's another study actually behind it, looking at what parts of the video the participants, or what, like when you look at the screen, were they looking in the corner of the screen? Were they always looking at the corner of the screen, or were they tracking what they were tracking? The person, the letters, the arrows. There's so much to it that we can do with it, but not sure if this is the stage of that. Because we need to first establish the protocol and then look into, maybe that will be the second study that we do following up that instead of a group design, to look at their attention and what they look at.
Are you concerned with loss of out?
That's why we have 6. So you single 3. Subject can be one. You can have as little as few as 3.
You don't think all of them will drop out?
No, because they go to school. they're part of the school system, that they can drop out.
And it's part of school that they'll come to this?
Yeah.
Oh, okay.
So they can drop out.
They can.
Like, there are no parents involved. And
They just walk right across the street to the,
Right.
actually to the gym.
Okay.
So when you select your patients, will you have some type of instrument to make sure that they meet your criteria for intellectual disability? Or
yeah, there's going to be a WASI IQ scale that we're going to look at, and we're going to try to make them as close in there. I mean, I don't think, based on the subjects that I already know, they're very close in their intellectual. I already know them, so I've worked with them for many years, so I know how close they are in their intellectual abilities and physical abilities. So making it a little bit easier on us, yeah. But in the future, we're going to be doing it based on the results of the IQ and possibly the results of not a fitness test, but how well they perform on certain, how well they perform certain exercises, and then we'll try to put them in groups if needed to, or simply stratify them if needed to. Like, they were a higher performing group to start off, these were, but that's a group design. I'm not going to go into detail of that, not right now.
And for your data collection is really like the video? Are you going to do like accelerometers or Fitbits?
No, there's no need for it, because it's really just cognitive learning. You're not measuring exercise, you're not measuring anything, you're just trying to prove that this strategy, educational strategy, is effective and teaches them steps, effectively teaches them at a certain pace, teaches them the steps that they can by a certain time, and we don't know how long it's going to take. We might find that it takes a long time, and we may find that it doesn't take a long time, that there's a one thing more effective than others. So we are going to be looking at the data rather than, it's semi-qualitative in a way. We're looking at the data, and this will drive our next study based on what we find. It's like a pilot. It's a real true pilot.
And what's the without video? So what are they doing without the
That's the baseline. We actually took that out because I don't think we can have that many participants. We would have to have more participants, 12 participants. And we would rather invest in the group design following up that. So do it staggered rather than do it concurrently.
Okay.
Yeah. So without a video, we're not going to do.
So you're gonna
no, just this. It would be probably just instruction. Not probably, but the plan was that we would do just instruction without presenting them video. Is that is that equally effective as presenting video or the steps in the video? How fast do they learn using verbal and physical prompting as opposed to video, verbal, and physical prompting? That was our first idea. Okay. But at the moment, we don't have the population and kind of the resources to do it at the same time. Okay. If we do it, that would be following this study, but we don't know where we're going to head up. Yeah, at the moment.
Just to see that strategy alone work.
It's very complex.
And what's your time frame for it?
Only till summer, because it's going to be one school semester. We're going to start soon. Okay. It's going to take about, I think we predicted 20 weeks.
And the video's already made?
Yeah, we're working on them right now. Yeah, and we're doing, we did the task analysis, and now one of my students is working on it. But yeah, we still have time, because the baseline, they will have to first start a baseline.
Pre-test the video, like with the
we will be testing, we will be testing the videos first, and there's content validity that goes into the videos. So it's a complex process. It's not just creating videos and popping it out there. That's just, it's more to it. Each step needs to be agreed by a committee that it's represented in the video. It's not just here.
And that's what you're doing now?
Yep.
And when that's completed, you'll start, and then that'll be done by June.
Yes, correct. It's all kind of happening at the same time.
And then this is really your pilot for a bigger study.
Nobody has done it, so there's not a draw from.
And it's the Western Y that's your partner?
We're partnering with the Ys. With all Ys. We're planning on using this strategy, actually.
And you provide the iPads or whatever.
Uh-huh. We're planning on infusing it in other programs without really doing the research as well, once we find this effective.
The Ys are generally becoming much more forward-thinking and wanting to be more inclusive with the folks, with individuals with disabilities in their training sessions, and they have just been, really positive, in that way.
That's awesome.
The response we get back is it's the right thing to do. That's been a really nice approach.
Do these 6, the individuals, do they learn with video in other contexts? Mm-hmm. It's not like, so they're used to this as learning.
They're used to iPads.
Used to iPads. Watching and following direction.
Just like any, again, within any instructional program, you're going to have technology built in.
Yeah.
And these guys are so technology savvy that this is just be another step.
It just allows good. This is not just done for the research. This is really done as an instructional strategy that's going to be used among interns, practicants, the personal trainers, because once they have the videos, there's consistency in the instruction that the person receives. We're planning, we're doing with EPIC, we're doing inclusion of these individuals, but there's no instruction on, or the personal trainers have no idea how to infuse them, how to teach them, and this is the instruction that they're going to be given. This is just a research that has much larger implication.
That it's effective before you go out and provide this for everyone, and everyone.
And we're going to be doing 12 videos. We're going to be developing 12 videos, and then the NIH application is going to be really to test all these 12 videos using a larger population. When they're included in the WISE, and how it affects their performance, how it affects their adherence, those are the primary, and their independence, those are the 3: independence or self-determination, their performance of the exercises and their fitness level. So there are really 3 components that will potentially measure. That is just, this has to be done to make that kind of step, because this doesn't exist. And if it does exist, nobody had tested it. So we have to have something in hand.
Do you have any plans to survey the participants themselves?
We will be doing qualitative.
Make them more likely to exercise? How comfortable they are with?
Yeah, we'll be assessing them via pictorial scales at every session, each session. So upon completion of the session, they will give us information how they like this exercise. Second, we'll be doing field notes with the instructors. And thirdly, we'll interview them at the end. And we'll also interview the instructors at the end. So all this goes into a qualitative data package, whereas the first one, the percentage, and the graph of the single subject design is going to test the effectiveness of the intervention.
Are you thinking of, maybe this is out of the scope, but do you think that there would be carryover back into their lives from being more independent and being able to?
That's why we do it.
And are you thinking of assessing maybe that?
That's what I said, the self-determination. We'll assess self-determination, not at this level. Why would we do that? It's more looking into self-determination when they participate in a full-blown exercise program. But that is following up, not this. I don't think we want to get into.
But you're also looking at moving from the supports giving during the sessions to these folks going into the Y.
Right, and just getting there.
And then the natural supports of the trainers there will be what they need. And they'll have all these things in play. The trainers will be trained so they'll know who these individuals are. And they can come in at night, they come in after sessions, outside of school hours. And they'll just promote their general health.
But all the Ys are doing it, or not all the Ys are doing it?
What do you mean all the Ys are doing it?
So the Ys are on board. But for you to do the second part of your study with randomizing, you would want some facilities that don't have familiarity with this.
Well, our
right?
partner is the COO of all of the Ys in Delaware.
Okay.
He's one of our partners in the community, so he is over all of the Ys. So yes, we have access to all of the Ys.
In Delaware.
In Delaware.
In Delaware.
But to start, it's going to be almost like the Glasgow Y and the Kirkwood Y, just for proximity to the university, proximity to the school, proximity to the client base. At some point, you know.
And then you can do the next
Expand.
Yeah, expand out
But that
from
will
there.
require partnership with Dover.
Right.
With Del State and that.
To
So
have the students.
to have the students from Del State go and assess in that area. There's much more to it. It will
You would
require
want our students
require
to-
NIH funding, and there's a model to it. I mean, it starts with accessibility, participation, adherence, and health function. So the final step is really health coaching, which, as I've learned, doesn't exist for individuals with intellectual disabilities. So that's another study to really conduct with somebody in our department, how to do health coaching of these individuals so that they truly improve their health via all these strategies. So if we're getting them into this model, what else can we do for consultation, like nutrition, drug abuse, healthy habits, and things like that? How do we change their behavior? But as I'm learning, nothing exists really for this population because most of the health coaching strategies rely on high IQ. So.
And the implications to this are much broader because as they build new Ys and renovate new Ys, they're looking at physical access and training of their staff to work with people with intellectual disabilities and physical disabilities. And it's been really a great partnership.
How are the Delaware Ys, are they connected to like national, is there a national like?
There is a
Y?
national, and the COO of the Delaware Ys has presented nationally about the different pieces that he's put like a harness system over the treadmill, so people either with physical disabilities or balance issues are able to use the treadmill. And he's put different pieces of equipment in, and he's done training differently with the people that are supporting people in the Y with his trainers. So he has presented nationally so far. So we're hoping that it spreads. It's great.
Is anywhere else doing it?
Not that we're aware of.
You mean following this system? No.
Yeah,
I mean, they're doing it
looking
in
at different types of
Chicago
interventions.
in certain, not instructional interventions. The problem is that they do accessibility. Most of the projects focus on accessibility and possibly how to motivate them to be physically active. But a lot of people forget that the physical activity comes with knowledge of how and confidence and their self-determination doesn't only come with, they're physically active, but how?
Right.
So looking at just physical activity like the accelerometers or whatever that may be is like a mistake. I mean, they are not the population to search or research them by their physical activity. Really, it's their feelings, their emotions of being a part of that group of the Ys and that feeling of independence
And being a part of a community.
This time, just a little bit separate, but it's inclusive of Eva's research. There is buy-in, at the state level. They actually put out a nice thing called the Y for All program and just kind of focused on, the harnessing system. But the governor was here, Rita Landgraf, the Secretary of Health and Human Services was part of it. So I'll just pass this around just to kind of get a sense of what we're talking about. But they're looking at.
They're looking at the Ys are supporting the accessibility piece component of it. They're making the effort.
The research component of it. Do you know what I mean? Like, do you think that the COO or the Ys in general see the importance of the research component?
Absolutely.
Yeah.
That's why. That's why they're on board with us.
Okay.
They're very
but our
confident.
partnership is the university, Epic, our organization, the equipment company, and
The Y.
And the Y. So we have a 4-group thing we meet. We'll be presenting it at the Life Conference down in Dover later this month, and we'll be having a nice collective group. So that's why the partnership's been wonderful.
Okay. Ready? You're up.
I'm ready.
Taste them all. Should we take a little break? I don't know. I never break. Do you want to do a little stretch break? Anybody have to go to the bathroom? we take like a 5-minute? Yes? All right, 5-minute break, and then we'll come back and do the last 2 groups, right? I don't know any yoga.
No, these projects are so
So it's a low start, but
well, for the DCC, I think I'm seeing patients in the afternoon, right?
Is it one?
Is it confident? 19.
Oh, right. Or do you have to use the entire service? And if you
third, yeah.
No snacks. Is that one piece that's probably.
Yeah. Well, it's usually just keep going, so.
From what I looked at. Feel fairly long. Yes, yeah, and I think, I'm thinking about that, Lindsay, from the perspective of the volume of questions already asked of a patient, just based on our tool from the DNA. So
do you have a stand-up desk?
Let's
Get one of them.
Okay.
Yeah, she put together her office and then she decided to.
Right, okay, well, that's why
She built one that moves or like a stationary?
Stationary stand desk.
Well,
Back to,
right.
When I went back to my last
Where?
Yeah, I was just looking
I was there
at
about
that,
3
yeah.
years. My first 7 years I was in school for hotels, and then I was in school.
Because they're switching to tools.
I was director of communications and then I went to a project up in environmental health sciences, but it had to do with the grandmother story. So it was stress and cardiac risk, and it was really cool. It was a cohort from.
Well, this isn't,
These high schools in Baltimore.
It was.
There's the right age, right?
Yeah.
And it all.
Yeah. How was your holiday?
No, actually, it was on
Henry.
Henry.
It was like 50 degrees in distance. I mean, that was just over. I'll take that.
Well, we live on a strong side. It was like Christmas Day, and like, about 11 o'clock, 11 a.m.
Right.
You walk out in your skates, everybody in their skateboards and their hovercrafts and their this and their that.
That's great. Good for you. I was just thinking about,
And then I worked at the University of Baltimore for a long time with one named Maureen Black.
And going back to school, we're really easy transition, right?
Yeah, so I worked with her for
And so
Oh, really? That's this week. So yeah, I'll tell you, they were better than I thought. I got less wine than I took. So who knows? Maybe
I know a little bit about it, but Jenny was on
next
this
week.
project.
It'll be this challenge. Like the first week is.
Oh, no, they're back to back. Only a few days teacher. There's no fallback now. They're going to work.
That was one of the places I looked at when I was looking at
In my
well, yeah, this whole like.
It's been very eye-opening, this whole process. So thank you for including us. Obviously, we did talk about research, but we can become more thinking. Talking off now. I prefer that.
What I was thinking about this was
I have a broader understanding of self. It's very simple. Thank you. It's just different couple sessions.
So when that's really, I don't know why I think that, but whenever we were having a conversation. So,
I understand that.
I mean, I think.
Yeah. Videos she made.
So she was speaking for
Exactly, like this one here, I had one, but it came from oncology, and I was really surprised.
Great one.
I mean, from quality of life, but it came essentially from oncology, and yet, she couldn't find it.
No, but So I'm curious, I was playing around with the idea of your responses that community church did. So I was playing around with the idea of trying to sort of condense it a little bit. And what I would do is I was thinking about taking all the didactic and having them sort of
So they get around it. She's in a code. They put her in a code.
and then the sessions would be just come with
And
questions.
then, so
It's
I
like
think
flip a
if
classroom,
I've done
use
this
this
myself,
and they didn't do this.
yeah.
But,
Use
the
McGill.
center was just.
They put her on the better
You know, so it's like, I'm thinking I'm going down to my teacher. Up on the board, she'll put sheet. And then, when you read this, you shouldn't have been able to learn this, but now here's an opportunity to come together. But I just think they just gotta be, in a videos and the reading, there's gotta be a level to where.
They come back.
Not just.
They do come back.
Just enough.
They do come back. And so, in other words,
But
25.
I'll say, you're right.
I mean, it's
Sessions have
that,
folks give it up their Thursdays, but we.
So he puts her on.
So you didn't lose it, but just saying, a little adjustment, it might be fine.
And that lasted for a while, and she came back like a dynamic.
Yeah,
I still say
this probably would work better if we had that, we had.
And I see traceability in your
So do you stay and do one day and tell what you're saying that is then beginning of the session?
Oh, absolutely. She didn't know who we were. She was like, she was
Well, and we can do that. I mean, yeah, we can do that. And then that way,
close the rug. She would have to run her. She would say,
Discussing.
and we could probably set it up so that
I would always know the video she had to be alone.
Yes.
So she was
Yes.
scared all the time.
Then you can come out of it with.
Yeah.
So I think in the beginning, because of lack of oxygen, there were some visual issues, and I think there was a delay, developmental delay, up to maybe 20 months, but she was getting.
But I think we should use this because it does give you.
That lived a little, I don't think she had intellectual disability.
There is like a 50-minute to read to so there's a training ground called CSX.
So,
But it's like for trains that just move things.
Yeah, so I've seen that on the side of the train.
So they own part of the rail, that's where it started. So why would they want to give it
I should do something about that.
So they could get that or.
Like, he looks at refugees. Why would he use hospitals to
What was supposed to be started like 2 years.
That's the first thing that she did.
And they were supposed to bring in the trains and fill the New York trains. Right, yeah. So it's coming. It's just, they're all not treated still.
But the obstetrician would be very, very nice.
So that's as good. I mean,
So,
Well, and then, well, when you and I talked about that, would we not want to use the same survey?
and this has just been.
It costs like 5. It's got a time frame on it.
Age
The more money.
Other states is 21.
I don't know what's going to happen.
Like, when I except that I hope they have it now, that I would hope that was what the hospital
There is like.
But,
I don't think, I know she doesn't know that.
I've done from the judge for everything.
But I would think the university,
So I was an intern
Medicaid, it's just Jefferson
and the community.
Well, there was such a community
This was
coming out and they would have.
I think this would be much more inclusive. And when you go down, it says patient care.
All right.
Yeah.
Everybody back. So, all right, we're gonna go and move towards healthy food. So we're all probably hungry or getting hungry, so we can talk about. All right. So, Lainey, ready?
I think I'm ready.
All right. So.
It's up there really beautifully. So, so actually, Allison has this great term, which I now think I understand better. in our proposal, it says that this research design is for, will be a withdrawal, reversal, single case design with 6 one-week phases. Can you explain that?
That's a good one.
Because I get, right, withdrawal / reversal, single case design with 6 one-week phases. Now I get that. What makes
So
it
1 week it's going to be there, 1 week it's going to go away.
Well, it's going to change. I mean, it's going to have several different iterations. So I know that we'll be going to the zoo in the spring and the summer. We'll be doing surveys that we're co-designing with the zoo to sample people before the intervention. And then once the intervention is in place, we'll do another sample. The N of 200, I don't know if that's going to be 200 before and 200 after. We certainly could do that.
But in